aspiration and differential assessment of the cyst contents, and trying to determine which is best in diagnosing mucinous and non-mucinous lesions of the pancreas. As all this audience is aware, pancreatic cystic neoplasms are historically at least said to be uncommon, accounting for around 5% of pancreatic tumours, these in resection series. However, we all know that with the advent of cross-sectional imaging, this number has increased significantly. Furthermore, autopsy studies would suggest, in the elderly at least, the figure may be much higher. The importance is that the pancreatic cystic neoplasms represent a heterogeneous group of lesions, and it's important that we identify accurately the mucinous lesions, as these certainly have a malignant potential. The question is how we go about doing it. There are lots of different ways described in the literature, but one of the most popular appears to be the use of endoscopic ultrasound and cyst aspiration. However, there's another dilemma then as to what should we measure within the cyst. Cytology would seem an obvious target. If we find malignant cells or severely dysplastic cells, then we would all recommend resection. CEA, based on this data from the Mayo Clinic, would suggest that a level around 200 or 192, to be precise. Levels above that would indicate mucinous lesions, and maybe these should be resected. Amylase indicates a connection with the main pancreatic duct. Again, may be useful. For the future, molecular markers may be important, but one different factor that we've looked at previously is MUCIN. In a small study conducted at our institution of 87 patients, positive extracellular MUCIN staining had a positive predictive value of 83% for the identification of mucinous cystic neoplasms. Our study aims, therefore, were to look at the cyst fluid analysis and to try and determine if this could accurately identify cyst histopathology, and also then look at the subgroups of CEA, mucin and cytology separately or in combination to see if we could define